If you can barely see it, there's a dissection. So this is a 34-year-old woman, undiagnosed aortopathy. She's stable, but the ER doc, as soon as they got this call, they're in a community hospital, immediately calls and says, we got to get her out of here. And our university hospital is only 10 minutes away. I want to show you, this is the axial view, same pictures, but a little bit easier to see how enlarged her aortic root is as we come down here a little bit further. And this is the only imaging we get, because now we have a baby that we don't want to do further contrast studies with, or radiology studies. But you can see here in the ascending aorta, there's a clear dissection plane. And as you get further towards the root of the heart, this is a pretty big aneurysm. So the call is made. And we do a rapid assessment there and on the phone. And as soon as we hear about it, we get the neonatal team, the PEDS hospital, the maternal fetal health, OBGYN, the ER, the OR, and about 4 surgeons, probably CT surgeons, because we are going to have to be fast and good. We have no evidence of malperfusion. The baby is stable heart rate. We do a bedside TE. She does have moderate AI, looks like a bicuspid valve, and she has a normal EF and no effusion. So this is, we already know we're in a pretty stable state for the mom. So we know with dissections, every minute matters because your risk of mortality goes up with every hour. So she has special issues. She's got a bicuspid valve and a root aneurysm. And you'll see on the image to the right, this is pretty typical for someone with Marfan's. Now the patient had thought she had Marfan's, told her OBGYN, even or primary care, even before she got pregnant, that she thought this might be a possibility because she's a nurse, she's aware. No one tested her for it. So she goes ahead and now she's pregnant. And we're in this situation in which we probably, again, number one, identify the problem. The patient told her doctors what to do, and they just didn't. So now we're in a little bit of a worse situation. And this is what a dissection is. For those who may not have been on their cardiac surgery rotation yet, it's a tear in the ascending aorta that allows a false lumen to develop with blood flow that can go all the way down into the descending. We don't know in this patient where it ended because we didn't redo the imaging. She had palpable pulses though, and again, no malperfusion in the abdominal or cerebral vessels. So we are in, we just know that we have to take care of this to basically bring those 2 walls of the aorta back together. So, let me go back. There we go, sorry. So the goals of this, we know as soon as we're transporting the patient, so she's only 10 minutes away, and we're talking as a team. We know this is an emergency. We're gonna have to fix that primary tear. We have to seal the false lumen to prevent ongoing aneurysmal dilatation and possible rupture distally. And we have to maintain a pressurized true lumen to resolve any abnormal or malperfusion. So the guidelines are pretty specific, even in pregnancy, for what to do with a dissection, a type A dissection. And number one, and I just put this in here, is, you know, if you have someone with Marfan's, get genetic counseling, number one, but also fix the aorta, even if it's 4.5 centimeters ahead of time, because they're going to be at risk for this dissection. And so this would have been a conversation that our primary care could have precipitated, gotten appropriate imaging. So that's number one in the guidelines. Number two, this is, again, even if your root is dilated at 4 centimeters, these are risk factors for dissection in this young patient population. So this is even more acute and important in those patients with the aortopathies. But if they present with a dissection during pregnancy, the most important thing is to consider where's the baby at. And if they're in the 1st or 2nd trimester, you go ahead with the aortic dissection repair, but the chance of fetal loss is extremely high. This patient was 4 days into her 3rd trimester. So luckily, the OB person felt that we could save this baby. So this is moving into the class 1 indication that we're going to first do a C-section, and then we're going to do an aortic dissection repair. And we were all like, okay, here we go. And then the other question is, what normally, if you could resuspend the valve, save the valve, you would do so. But again, this is involving her root, so we know we're gonna have to do something with the valve. There's just a discussion at our national meeting in bicuspid patients with dissection. Can you do a valve sparing operation? And it's possible. And usually you want to make sure that you have a good experience with that before you attempt it. But in a young patient, you really prefer to save the valve. However, this is a degree beyond that. This is a patient who's going to now have a C-section, and you're going to have to fix her valve and her ascending. We discussed this with her ahead of time. She's like, I'm not having another pregnancy. So we were good to go. And so what we made the plan then, what's her risk? Mortality risk was 3 to 20% for the mom. Turns out the baby's risk was quite a bit less because we know he's already stable and into the 3rd trimester. So that was the good news. And the mom was stable. So we felt we could get a pretty low mortality risk for the mom as well. We made our plan. It involved over 30 providers in 3 different hospitals because we have a separate pediatrics hospital. So once the baby was delivered, it had to be transported then to the NICU, which is again, just only a little ways away, but involves a number of transport people who had the expertise to handle a newborn being transported and also bringing the mom to our university hospital. So there was a huge amount of conversation going on and cooperative effort. And I have to say, I was really proud of our teams because they called the OR and like, we have this, we need to have the NICU ready, this and then they're like, okay. And that was it. So we were in the ER waiting for the mom to come up, and it had to be fast, and we had to be really talking to each other and have good teamwork and rely on each other because I haven't done a C-section in about 20 years, so I wasn't going to do that. So our operative strategy is we knew what we had to do for the dissection, but from the moment we got the call to the baby was delivered was 45 minutes, and we can barely get someone like scheduled in 45 minutes usually. So it was a very impressive. I think we were all totally freaked out. So this was a disaster for all of us. We did not want to make a mistake. And then we did our standard ascending aortic repair. We removed the aneurysm. We did it in a way, we have done a lot more dissections in our institution in the last 5 years than we probably had done in 20 years prior. We've learned that we don't cool as far as we used to. We go to about 24 degrees. We use retrograde cerebral protection routinely. We don't do antegrade, and we do central cannulation with ultrasound guidance. So it's pretty quick. Not a lot of dissection, not a lot of room for areas to get infected or have injuries. Because again, we didn't know how far this aneurysm went distally. So it's actually a little easier to handle centrally. They wanted to close the abdomen afterwards, and I'm like, nope, we're gonna leave that open. We're gonna be in circumrest. We may bleed a lot. I want to know where the blood is. And they're like, okay. And they waited till we were done in the hospital to come back and close the abdomen, which everyone was like, they're staying, they're gonna wait in the call room. Like, and I didn't ask them to. I said, we'll call you back. And they're like, nope, we're staying. So it was a very dedicated team. And we were able to, when we got done, there was no bleeding. They closed the abdomen. And we were able to close the chest. The outcome, both mom and baby recovered really well. She ended up having to have a pacemaker, and the baby actually just had to stay in the NICU till it was full term. So it ended up having no neurologic injury and no growth delay. So we were extremely pleased. But they do have Marfan's, and this is going to need a lifetime of follow-up. And then we need to prepare for the next disaster, because I think we might have been able to do something differently, maybe been a little bit better. This wasn't available when we did this surgery because this has just become available. But 2 things for the baby, needs to be on different medications, needs to really have blood pressure control, probably will start in very close follow-up and really following the guidelines straight up. And then for the mom, because we have done this surgery differently, I talked about resuspending the valve, which I really don't think would have been safe for her. But I do think we had an option because now she's going to have lifelong follow-up of her aortic arch and descending aorta. Because these standard repairs, they actually will have the false lumen, with FL, patency of about 70%. So that means that there's going to be a pressurized false lumen over time that can cause an aneurysm, which can cause malperfusion, early mortality, and reinterventions. Reinterventions are quite common. And this can result in a long-term mortality or morbidity in 50% of patients. So she needs very close follow-up. And this is just an example of what can happen after you do just an interposition graft. And let's see if it plays. There you go. And to the left of the screen is a hematoma with, you can see, extravasation of blood. And this was a distal anastomosis of another patient after their dissection 2 weeks post-op, and it presented back with chest pain. So again, it's how can we prevent this disaster? And what is and again, this is just a picture showing the standard repair. And what are called veins or distal anastomotic new entry sites in 70% of successful cases. And how do you prevent this? And this is a new device called AMDS. It's an adjunct to your standard surgical repair that can be done at the time of dissection fairly easily and quickly. And I'll just show you the early studies. And what you see on the right is you replace the ascending aorta as you normally would, but before you fill your distal anastomosis, you deploy a stent that has big open interstices that can allow blood flow into the head vessels, but it's a really good sewing cuff. And that's what you sew to the aorta. You close down those false and true lumen, or you seal them together. And then you sew your graft, the interposition graft, to that instead of that fragile aortic tissue that can result in tears. And you deploy it through a antegrade. You don't need a guide wire in the same, like coming up from the groin like you do in frozen elephant trunks. So it takes about, I think, 5 to 6 minutes. And it's this you can see how big these nitinol interstices are. And these are permanent, of course, but they go into the distal, and you can just see how it's deployed like this. You sew the self like you usually would, and then you deploy this nitinol graft, and you sew to that. So it's a very robust anastomosis. And in the first studies that were done in Europe and Canada, they showed that in a multi-center prospective trial that include dissections with malperfusion. You had CT scans done at baseline, 3 months, 1 year, and annually. When you looked at both mortality and then their secondary endpoints of malperfusion and aortic remodeling, what they found was most importantly is because the stent only goes to zone 0, which is the ascending zone 1, 2, and 3. It doesn't go into zone 4, 5, or 6. But if you look at the 0 to 1 and 2 zones, 75% had no further extension of the aneurysm and no further dilation. And the false lumen flow had stopped. So in the zone 0, of course, that's where your standard graft is. You're not going to have any remodeling there, but it's the arch that you want to look at. And so there we're showing within 3 years, significant improvement. And this is something I think we could have used in our patient. Now, right now they're saying it's not indicated for those with aortopathies, but at 32, to have reduced mortality, reduced malperfusion, and reduced aneurysmal dilatation of her arch, and may prevent another intervention. I think that's what I would have wanted if I were the patient. And now there's a PERSEVERE trial, which is in the US, and this is available. You have to, they still want it to be where you have IRB approval because it is a new device, but this is a randomized controlled trial. At 5-year follow-up that will complete in 2028. They're already seen on this slide at the bottom, you can see 79% experienced no major adverse events. And you compare their experience of the PERSEVERE to historical references, which are a little all over the map, so it's not a great control group, but they're all-cause mortality, and these were patients with malperfusion was 13%. For most studies, it's about 30% mortality if you have evidence of malperfusion. So you're immediately restoring blood flow in a better way. You had less stroke, you had less renal failure, and they had no myocardial infarction with 98% technical success in a brand new device. So that always tells you that's a good operation. So this is where I think we could learn. And our future plans is we are getting this on the shelf for our institution. We all have been trained on it. Everyone has seen the advantage of it. They see it as an adjunct, and we move It moves the disease distally into the country. You can now access it through descending endovascular techniques. You don't have to do the arch repairs if you don't have the aneurysmal dilatation of the arch. And it has current FDA approval, although we don't know the long-term outcomes. Now you're putting another device into someone's arch, but we know that they already have trouble there. As you're saying just today, the M&Ms in cardiac, it's a diseased aorta. You know it is. So doing something in it is helpful. So that's learning from your disaster. We are lucky with the success. It made the team feel really good. And that's your ER situation. This is more, this is going to be a disaster. This is a 72-year-old woman who has severe MR, and she has a history of diabetes, hypertension, atrial fibrillation. Her BMI is normal, but she has a significant past medical history of a prior pacemaker. She had an ablation, and she had prior coronary disease with PCI and CERT, and that were all patent. So we thought, okay, sure, we need to take care of this patient. But she had an angiogram with pretty diffuse disease, but everything was open. But our PA pressures were 60/38, pulmonary hypertension, and her TEE showed severe MS. And so we're like, okay, this is someone who needs her mitral valve replaced. She has pulmonary hypertension, that's to be expected with severe MS. But she also had moderate to severe AS, which is rather unexpected. She had mild AI, trivial TR, and a normal LV function. We're like, okay, now we're up to an AVR, MVR valve replacement. But she's got a normal EF. She's pretty young, normal size. This should be fine. But the CT scan showed severe MAC, which is mitral annular calcification. And it was circumferential, and it extended into her papillary muscles, and she had a hypertrophy ventricle. So as you look at the CT scan, which we get routinely on our patients, you start to see the calcium posteriorly in the annulus. And then you realize, well, this is going to be a problem. Not only because it's going to go up into her aortic valve area. It's going to be very hard to remove. She has very hypertrophied ventricle, so it'll be really stiff. And although it goes onto the papillary muscles, it's clearly in the annulus, which can be a very delicate structure. And she's a high-risk patient because she's female, diabetic, renal disease, and she has some osteoporosis. And that's like every risk factor for someone with MAC because they're delicate, they're small. And so you've got to try and get in a right-sized mitral valve, but she's going to have no pliability of her annulus. And then the mitral valve mechanical stressors make it hard because she's got a thick heart from her AS and she's got hypertension. So, why worry? We can fix it. Well, atrioventricular groove disruption is lethal. Maybe you might save someone once, but most often it happens where the heart just basically the atrium pulls off the left ventricle. And if that happens after you put a mitral valve and aortic valve in place, your ability to stay down will be very hard. So the risk when you see MAC are death, stroke, MI, and atrial fibrillation. And the technique currently for this is you take out the debridement and then you patch it with the bovine pericardium. And you can see to the far upper right where they put in a patch and then they put in the sutures for the valve and then they seat the valve there. But again, they're sewing to a very fragile, the fragile endocardium. And so this can be done. But when you start sewing to muscle that's been sort of torn up, you've seen this with abdominal repairs. This is when you know you're going to get like a hernia, something's not going to hold. And that's the risk of this operation and patch reconstruction as well. So this was, again, planning ahead. I was just talking to my partner, worrying about it, not really having an alternative plan except the patch. He said, I just saw a video from the University of Michigan where instead of taking out the calcium by debridement mechanically, they emulsify it with this CUSA, like they do in liver disease. And I'm like, no way. Like, do we have a CUSA? What is that? And I'm like, okay, you're helping me. We're going to get the CUSA and we're going to try this because we knew short of this, we could end up with an AV disruption. So we planned our AVR, MVR maze left atrial occlusion device. But this is our initial view in the OR. And this is the mitral valve from the surgeon's view. So the head is to the left, ear to the right. We could barely get a 23 sizer in. So we normally need to get up to about a 29, 31 valve in for this person this size. And this was rock hard. It was circumferential. We couldn't even see into the ventricle, but you have a hint of the papillary muscles right at the center, which is like a little pink. So they are totally contracted up right to where we're working. So we had a good view, we just couldn't get there. But this little video just we started to cut out the valve because there's no way you can retain these coronal leaflets. Well, now you have a little bit of an opening, but that was just taking like the 20% that was soft out. And then we started doing our standard, which is really pretty brutal. We just kind of carve out like an orthopedic surgeon, all the calcium. But this is, then we have a section there, and we're kind of retracting things. But this part's fine to take out because you're not tearing anything except the leaks within the calcium. But this is where we wanted to really start using the CUSA. And the CUSA is in the right, and the suction right there on the left. Because you can see how you're disrupting little chunks of calcium and immediately sucking them up. But what you're not disrupting is the endothelium. And so we were kind of amazed and sort of freaked out because you're also throwing little debris everywhere into the left ventricle. And your risk of stroke, you think, is going to be astronomical. But you see how the suction is right there next to it. The CUSA has some suction capability. We're actually able to clear out that whole area and retain the endothelium or kind of above and below so that we could then sandwich it together with the pledgeted sutures from below and using the sewing cuff of the valve above. And it's really slow work. But by the end, we're like, okay, we can actually size it up to 27, and we ultimately got it up to 29. And with an aortic valve in place, that usually compromises your mitral valve. You don't want to oversize your mitral and then put in your aortic valve. So 29 for her size, we were thrilled with. That's what I normally would have probably anticipated. But mostly I was happy with the fact that we were able to put in stitches that felt very secure. With the risk of paravalvular leak felt like this was going to be great. And this was our final result. We actually got in our standard valve. We were able to complete the operation. In the end, we had normal sinus rhythm, we had no stroke, and we had no paravalvular leak. And she was discharged home in postoperative day number 8. So this to me was a great example of, call a friend, talk to somebody, think of new ideas, use a new device. We had never seen this before, but we watched a video and we were able to implement it. Because I think in today's age, you should never go into an operation you've never seen before without watching a video of someone else who's tried something, because it's so much clarity and it makes it so safe. And I think we have the tools as surgeons to implement technical solutions. So then my last case is just to more demonstrate again that step 1, use everything in your knowledge to make sure that you're doing the right thing for the patient. Because this was a 65-year-old gentleman with post peripheral vascular disease and COPD, had endocarditis replaced in 1993 with mechanical valve. In 2008, he had a second operation, reduced sternotomy, because he developed an ascending aneurysm, and this was fixed with an interposition graft. And then he came back in 2018, and he had endocarditis with staph. Now was treated medically, and the fact that he was able to recover on antibiotics alone, he's in the 30% group. That's very uncommon. Usually you have to replace the graft at that point. But he did well, and this was 6 years later. So now he presents with a non-family. He's got heart failure at EF of 30%. And on the upper left is his mitral valve. I see it's quite loopy and stiff. But we also got a CT scan, which showed his pseudoaneurysm, his ascending aorta. And he had distal graft anastomosis that was abutting his sternum, and clearly not any space in between. So the risk was we needed to take care of his valve, but we knew we were going to get into that graph. There's just no way around it. And we expected that because he had AI, because now he had severe AI with his valve, that he was going to, if we just went on bypass and cooled and tried to open the sternum, his left ventricle with the aortic insufficiency was going to dilate. And yet we couldn't get to his left ventricle to decompress it through the sternotomy. And we were really worried that with that, he's going to have post-cardiotomy shock and cardiogenic shock. So the number one was we wanted to make sure he was in the right hospital to handle it if we needed to have device support afterwards. And we also had to have multiple teams to get into this chest quickly. So the operative approach obviously is multidisciplinary. And this is the first time I've written down every step. It took about 3 pages. So that the nurses could see exactly what we were going to do. In about the middle of the page, I said, and this is where we panic. And the nurses were like, what? I'm like, yep, that's where we're all going to say the wrong thing at the wrong time. We're going to say stupid stuff. It's not going to make sense. But this is what you're going to have 4 different things maybe ready for this moment of panic. And it was really cute because they're like, okay, we're ready. You're going to panic. And they same with the perfusionist, because the perfusionist has got to hold it together. Like, we're going to hand off the wrong lines. We're going to give them the wrong things. And they got to just say, nope, this is what we're going to do. So it was helpful. And at the end of the day, because like I said, I usually don't do that. But we have a lot of chaotic, you just saw a lot of chaotic surgeries. And if you anticipate that, taking the time to write it down, go through it with the team, it made everybody just like the temperature in the room just went way down. And we knew we had to get into the peripheral access because we had to decompress the heart. And then this is something that, again, just phone a friend. I don't do heart transplants or LVAD, but my partner does a lot. He's done a lot of minimally invasive. So he's done a lot of left thoracotomies to do left ventricular access. He's like, sure, while you're getting the groin out, I'll just open the left chest. We'll do, mini thoracotomy. We'll do a little purse string on the left ventricle apex. And just as you go on, I'll put in a vent. Okay, that was great. Solved that problem. And then we knew if we rupture, we couldn't arrest the heart. My other partner said, I think what you can do is just give 80 milliequivalents of potassium systemically and just arrest the heart that way. I'm like, you can do that? Okay. So that was like, now we're going to panic. Now we're going to give potassium. And so we wrote it all out. And that's exactly what happened. We opened the chest. We were on bypass. We had cooled already. So we knew if we were at 24 degrees. I think we went down to 20 because, again, we wanted a little more time. And we knew we had left ventricular vent in. So if the heart fibrillated as we were cooling, we were still fine. And then as we opened the chest, it just shot out, right? And I panicked. I'm like, oh my God. And my partner, who was just kind of there for some, watching, said, isn't this where you go on circ arrest? I'm like, oh yeah, we have circ arrest. So we stopped perfusion, gave potassium, heart arrested. We were able to open the sternum quickly because you saw it was right there. And we just reached in and put a clamp on. And that was it. We're like, oh, okay, go back on bypass. And so we took 9 minutes. And then we closed a little rupture so we didn't keep bleeding. And then we dissected everything out. And then we had used retrograde cerebral perfusion, but we didn't have that for those first 9 minutes. So then we put in a superior vena cava cannula to do the retrograde. We removed all the old floor material. We had to take everything out because we had a paravalvular leak of the aortic valve. And we did a Ventol with a biological conduit. So similar to our woman who was pregnant, but in this case, we used the biologic material due to his age. And we did the same ascending and root repair. And as a result, we had no intraoperative complications. We didn't even have to transfuse him because we were under control already and didn't need balloon pump or even ECMO because once we fixed the valve, even though his EF was low, his heart was able to function well, and we didn't have any time of no myocardial protection. And then at the end, there was no paravalvular leak. He had normal EF because, again, we had reduced that AI, severe AI from the valve, and he had no stroke. Now, that's just luck. The no stroke part was just luck. But he was discharged home in post-operative day number 12, and he didn't have a pacemaker. So I just demonstrate that because I had 4 colleagues in the room for that case. I did not do this case alone. And even talking about it, I had 2 colleagues who made really good recommendations. The nurses also double teamed. so did anesthesia, and so did perfusion. Now, it seems like a crazy amount of resource for one person, but we didn't have, 2 months in the ICU later. We didn't, it doesn't have that. And I brought him from another hospital because the other hospital didn't have these resources either. And the patient was fine with that because he knew this was his third reoperation and he knew it was going to be a big deal. So in conclusion, you don't need to be a superhero. It's all about being a firefighter, being prepared, knowing what your team is, over communicate. I can't stress that enough. And then lead and innovate and be ready for the next disaster. Thank you. And I have time for questions or any comments or thoughts. I'm sure everyone in the room has had a similar experience.
That was a great talk and sort of really important on the heels of M&M and how you process all of the things that you go through, both sort of technically and then emotionally too. And what would be your advice for those folks who are just getting out into practice in their early years? How to navigate sort of the communication aspect? Sometimes you don't know what you don't know. So how do you advise those going into their first couple of years?
Well, I will say I learned this mostly at LA County, where we didn't have someone always available. I did my first API with a med student because they said, well, you should read about it because you might have to go do it. And I was, okay. And you don't know what you don't know. And luckily, there was a nurse in the room. I kept saying, am I doing this with how everyone else does it? And they're like, yep, you're fine. Keep going. And so I think even every small learning is like building on your understanding of yourself and what you're capable of, but also like who's around, your judgment of who is around you, who I ask for. And I think that's where it starts. And then the other thing is, I tell this to every fellow, your best friend in any bleeding is pressure. And just put pressure on it. It solves almost everything. And then you have a moment to call for help, get everyone in the room, tell everyone in the room. I think your first thing is like, oh God, don't tell anyone. I just made a mistake. And I trained the exact opposite. I will say, I just made a mistake. This is going to be a problem and I need your help. And then everyone can help you. Because if you don't tell them, you are just going to go down that hole all alone. And they're freaking out too because they don't know what's wrong. They don't even know how to help you. I think those things I've learned in general surgery. And then when I got into CT fellowship the first time as a first year fellow, and we were closing the chest and suddenly the pressure had gone up to 200 and the cannulation site ruptured. And I'm in there as a first year without even a PA, it's just me and the nurse. I just put my finger on the hole. I said, you better call Dr. Central Marina back. And then we just waited. Like, I didn't try to put a retractor in, didn't try and do anything. And I told everybody to get blood in the room, tell the anesthesiologist, and everybody came back rushing in, and we were fine. But I didn't try and fix it without having help or blood and anesthesia or anything else. I think the attending panicked. He was like, oh my God, I have a first year. Don't you remember? But I think those are the things I've learned.
Rose, that was a great talk. And I think you have always embodied this idea of leave your ego at the door, ask for help. And I think sometimes that takes actually a lot more personal strength than trying to take it on yourself. I would just say to everybody, when you go out and find your first job, look for a culture where that is okay. I'm aware of many situations where asking for help is punished, it's looked down upon, when in fact, I think it shows the greatest amount of strength to ask for help. And it doesn't matter what your level of seniority is to just say, listen, this is going haywire. I should get reinforcements here. It's about the patient. It's not about our egos. But I'm sad to say that I think our world of surgery doesn't do that enough or doesn't appreciate that as much as it ought to.
I will say it's definitely about culture. When I called for help as a first year fellow, of course, you're expected to call for help. And I stayed where I trained. So I already knew the culture and I knew that was okay. What has been fun over my career is influencing my own culture to make that more okay. Because as it wasn't always that way at all the hospitals we cover. And then my partners start to realize, well, this is less stressful. Like to have someone else in the room who actually knows how to help you and can have ideas and you can get out of it. And they're not under the same stress you are. So they're like, when I go to help my partners during a dissection, so we always have 2 surgeons show up for a dissection. If it's straightforward, the fellow does it. But if it's not, you immediately have someone who can help you get cannulated and get moving or do whatever. And if you're the second surgeon, it's like, well, this is fun. I get to just come in, do the really kind of exciting part and leave. I don't have to stay for the meeting. I don't have to be there open. I don't have to I just get to do the fun stuff. And if you don't need to do anything, I just get to go home. But once we started doing that with dissection, our mortality, which was probably in the average, about 10% with dissections, it's down to like 3%. Because you also have someone else who says that 89-year-old, because the dissection with malperfusion, we shouldn't be operating. And your partner's like, well, but I think we should transfer them. Nope, don't transfer them. Because now you're going to transfer them away from their family, go on a helicopter ride, and they won't survive. And you have someone else making that really hard decision with you, and they'll take the hit with you. And as you say, to your reputation. So it's been extraordinary to see how our mortality got so much better, our outcomes got better, and our own personal stress got better. And the fellows get to do actually more with the second staff there. Because like I'll say, well, I think they can do the distal. I think, let them do that. Do another circuit rest. Because if it doesn't work, we're right there to fix it. So it's been interesting.
Thank you very much for your talk. I'm Jimmy. I'm the 33-year pediatric surgeon here. So I've evolved in my career from the days where you're doing an appy, as an intern or whatever it is, to interacting with lots of different people. And what you just said is so important, I think, with regard to your partnership with your colleagues and peers in operations. And in our practice, I hope 2 of my partners are away right now, one's here. I hope they all believe the same thing, but we've tried to foster a culture of helping each other out and scrubbing together. And there's certain cases we always double scrub. And now we're very mindful of what the residents are experiencing. Even in those quote double scrub cases, there may be a situation where you're helping the resident do part of it, but the other attending is there looking in or giving it, and all of those things are true. One, it's wonderful operating with your partners. And I think it creates an esprit de corps that is very helpful. Secondly, that you're right, that second person isn't under the same stress as the first person, but it can actually lower the stress in the room. And I think creates a good example for those we are training to say, partnership is a good thing. We have a new chief in our division, and he actually made a comment that spoke to that. He said, "You guys operate together a lot. I think that's really good." It's great to hear. So anyway, I think that I want to reinforce that concept and how important I think it is. And then it also it generates interaction later on when you're not in the operating room, right? Just in general, in terms of people helping out when they need to be helped out. Kids got a school thing, can you take this extra call? And I like to think that we foster that. But, so anyway, I just want to reinforce that concept.
And I will say, it really does make us appreciate each other more.
Yeah.
And even as I was talking about these cases, it was my partner's ideas and their skill that I learned from. And those discussions are sometimes very organic. You don't even realize you're asking for help. You're just talking. They were, free to give new advice. We got to try it together. And so we don't just get better, additive, we get exponentially better. And I think that's been a big learning. And then you think, financially, you're losing money. You're having 2 surgeons in on this complex all in one cases. It's actually, we're making more money because we're doing harder, more complex cases. And no one in the community wants to do these cases alone. It takes up their entire day. They're up all night and they have to cancel days and days of routine work that they can't afford to do. Their hospital needs them to do the routine work. They don't have a multitude of partners to help pick it up. And so it's turned out to be a very financially sustainable, even though you think you'd be losing additional income, it's because of the higher.
I guarantee you, this gray-haired guy learns from my younger partners every single day. So there's a great benefit to that as well.
Yeah, we get better together. Well, thank you very much. Appreciate it.
Human activities and moving. We're gonna take that way, you're not even.